Welcome to the ISHLT Pharmacy Community Webinar, the Protocol Paradox. Are we treating guidelines or patients? Our speakers today will be discussing protocolized versus personalized medicine in three different domains: transplant, PVD, and MCS. After the webinar, the recording will be available on YouTube. My name is Dr. Amanda and Jamie from Centera Health, and I'm joined by Dr. Mark Greer from Hanover Medical School. We ask that if you have any questions for our speakers, that you enter them into the chat, and after the presentations, we will open it up for discussion with our presenters.
Okay, moving on into the first talk, I'm pleased to introduce Krista Walter, a transplant pharmacist at the University of Michigan, who is going to talk to us about one size fits all or all for one, all in one precision and transplant medicine.
All right. Thank you very much for the introduction, Mark. Thanks to everyone for coming and for the pharmacy professional community for putting together this awesome webinar. I have nothing to disclose. So today I'm going to be reviewing our current practices for maintenance immunosuppression in our cardiothoracic transplant population. And then I'm going to move into discussing how we can individualize our therapy post-transplant by utilizing pharmacogenetics and biomarkers. So I'm sure it's no surprise to anyone on this call that our maintenance immunosuppressive trends in the cardiothoracic transplant population have by and large stayed the same over the past decade, with our most common regimen at discharge being a combination of tacrolimus, mycophenolate, and steroids. And so at our centers, we're following this protocolized approach where a patient is a certain post-operative day, and then we go through the check boxes and making sure they're on the appropriate immunosuppression and antiviral prophylaxis for that time post-transplant. But by following this protocolized approach, we're inherently ignoring all the factors that we know contribute to variability both between and within patients, such as intrinsic immunity, comorbidities the patients may have, other concurrent medications, pharmacokinetic parameters, and host immunity as well. Furthermore, this protocolized approach really represents a reactive medication management approach, where we are sort of waiting for something bad to happen, such as acute rejection or infection, before we're actually titrating the maintenance immunosuppressive burden post-transplant. And so with a protocolized approach, we're really falling into this one-size-fits-all single treatment regimen where we give everyone the same regimen post-transplant, and then there's a group of people who will respond very well, but there's also groups of people who will have poor efficacy or serious toxicity. And so I want to bring to the concept of transplant precision medicine, where we're really taking into account patients' pharmacogenetic analysis, different biomarkers that we have available, and considerations with their lifestyle to really come up with a personalized treatment that will balance both toxicity and efficacy for them post-transplant. So within transplant precision medicine, we already have several tools available at our disposal, both in the pharmacogenetics and the biomarkers field. Now today, I don't have time to go through all these in detail, but I do want to give you a primer on how we could potentially utilize these to individualize our immunosuppressive regimens and antiviral prophylaxis after transplant. So first, I'm going to talk about pharmacogenetics. And so CYP3A5 genotyping is one type of pharmacogenetic analysis that we can utilize to individualize our tacrolimus dosing post-transplant. So we know that single nucleotide polymorphisms in the CYP3A5 gene exist that then alters the CYP3A5 activity. So CYP3A5 expressors, who are considered normal or intermediate metabolizers, are actually recommended to have 1.5 to 2 times the standard dose of tacrolimus per CPIC guidelines, where CYP3A5 non-expressors, which is primarily most of the Caucasian populations, are recommended to have the standard tacrolimus dosing per package insert recommendations. And so where this has really panned out in transplantation has been in the kidney transplant literature. And so in 2010, there was a prospective randomized trial comparing genotype dosing to control. And there were 2 main findings in this trial. The first being that they saw increased achievement of therapeutic tacrolimus trough concentrations on day 3 with the genotype guided arm. And most of this difference was actually driven by the CYP3A5 non-expressor group, with significantly less patients in the genotyping group having supratherapeutic tacrolimus levels compared to control. Despite this, there was no difference in 3-month short-term outcomes, including nephrotoxicity, acute rejection, or survival. What makes this difficult in the cardiothoracic transplant population is that we're often using strong CYP3A4 inhibitors in combination with our tacrolimus. And so it's unknown if the CPIC recommendations for dosing tacrolimus based on CYP3A5 phenotyping can still apply. So this was a retrospective review that looked at the actual tacrolimus dose requirements compared to the expected tacrolimus dose requirements in a cohort of lung transplant patients in the first 1 to 3 months post-transplant. And the way they calculated expected tacrolimus dosing requirements was accounting for both CYP3A5 phenotype and a reduction based on the azole the patient was on. However, what this yielded overall was that using this expected tacrolimus dose equation that accounted for these two factors yielded very low efficacy, 40% at 1 month and down to 18% at 3 months. Accuracy overall, though, was improved in the CYP3A5 expressors arm compared to the non-expressors arm. And this is thought to have it's thought that the non-expressors had worse accuracy because they're actually more susceptible to the CYP3A4 inhibitory effect of the azoles. Furthermore, when they looked at the actual difference in dosing, they saw that this expected dose calculation significantly overestimated their actual tacrolimus dose at all 3 time points. So overall, tacrolimus dosing accounting for CYP3A5 genotype and azole dose reduction yielded very low accuracy in the first 1 to 3 months post-lung transplant. The other main thing to consider is CYP3A5 genotype guided tacrolimus dosing worth it? And so this was a cost analysis, a US payer analysis looking at genotype guided tacrolimus dosing compared to control in the first 6 months post-transplant. What they found, though, is that the incremental cost per avoided event was significantly higher for genotype-guided tacrolimus dosing compared to control for all organs investigated. However, the highest probability of it being cost-effective was actually in the heart and lung transplant population. And CYP3A5 genetic testing did result in reduced rates of adverse event despite this increase in cost. They then looked at different factors that could impact cost effectiveness. So factors that would make it a more cost-effective approach would be increased use of physician actually utilizing the CYP3A5 genotyping results, patients having a higher TAC time within therapeutic range calculated by the Rosendahl method with the CYP3A5 genotype guided therapy, and a higher prevalence of CYP3A5 expressors in the population in which it's being used. And the only factor that seemed to increase the cost effectiveness ratio was increasing price of the genotyping test itself. And so some things to consider if CYP3A5 genotype guided tacrolimus dosing is worth it in your specific patients or centers is really, I think it's important to look at the reason behind why you're wanting to use genotype guided dosing in the first place. So we know that it can give us an enhanced understanding of tacrolimus dosing and help us improve time to and time within therapeutic range, which can have downstream effects on a decrease in labs, number of dosage adjustments, which may in turn improve patient satisfaction and decrease medication errors. However, as I just showed, it is not necessarily cost effective, and its cost effectiveness is dependent on the provider utilization and uptake of using this test if you're going to get it. There's also no direct evidence for actually linking CYP3A5 genotype guided dosing to graft outcomes or a reduction in toxicity. We have unclear dosing recommendations in the setting of drug interactions, and then its utility is best served in a population who has a high prevalence of CYP3A5 expressors. So the next category of things I want to talk about within transplant precision medicine is the use of biomarkers. And so I have several biomarkers listed here that are commercially available. I don't have time to go through all these in the detail that they deserve, but again, hopefully I can show how you may be able to utilize these to help gauge someone's immune status after transplant and titrate their immunosuppression and viral prophylaxis accordingly. So the first one I want to bring to your attention is torquetemvirus. So this is actually a human non-pathogenic DNA virus that causes persistent asymptomatic viremia in the majority of the population. And what's unique about this is that its replication is associated with the host's immune status. So high TTV loads have been associated with an increased risk of infection in the transplant population, indicating an overall higher immunosuppressive burden, where low TTV loads have been associated with an increased risk of rejection, and therefore telling us that this patient has a lower immunosuppressive burden. So recently, there was a prospective clinical trial done in the lung transplant population using TTV as a way to guide immunosuppression titration after lung transplantation. So in this study, adult de novo lung transplant recipients were randomized to either have tacrolimus adjusted based on TTV viral load in combination with therapeutic drug monitoring or conventional tacrolimus therapeutic drug monitoring. And then depending on what the TTV viral load was, the tacrolimus was either increased or decreased by one immunosuppressive step. Their primary outcome was change in 12-month eGFR. And so here are the preliminary analysis that was presented at the 2025 ISHLT meeting. The full results are not yet available, but there was 164 patients in this study. They found that tacrolimus target troughs were reduced more often in the TTV arm compared to the conventional arm. Despite this, there was no change in 12-month eGFR between the two groups, but it did show that this was safe as there was no significant difference in acute rejection. However, there was an increase in infections in the TTV guided tacrolimus dosing arm in this study. So then some things to consider when thinking about TTV is that the cutoff values have not been super well defined. There's several cutoff values proposed for the detection of rejection and infection, and they vary based on the organ it was studied in. There's also limited evidence for using this in an interventional study in the cardiothoracic transplant population, and the relationship between graft outcomes is not well defined yet, but we do know it can help us identify those at risk for rejection and infection as well. The next biomarker I want to talk about is the use of cell-free DNA, which many of us use in practice today. It's a marker that can help us identify allograft injury and has a very high negative predictive value for ruling out acute cellular rejection with pretty good sensitivity and specificity as well. There are several false positives or confounders that can also elevate cell-free DNA as well, most notably infection. And so how is this being used in practice today? Most often it's being used as a screening tool. It's been shown that it can help us detect AMR and ACR earlier. It's also been shown, been used as a prognostic indicator with an increased risk of mortality in graft dysfunction or failure shown in the heart and lung transplant population with persistently elevated cell-free DNA levels. But what I really want to focus on today is its use as a monitoring in terms of how we can use it to titrate our immunosuppressive burden, whether that be as a response to a rejection treatment, to reduce immunosuppressant overall, or in the setting of complex pharmacodynamic interactions such as immune checkpoint inhibitors. And so first I want to highlight that cell-free DNA actually inversely correlates with tacrolimus trough levels and adenovirus abundance. So adenovirus is of the family of tortenovirus. And so in this recent study of lung transplant patients, they found that both acute rejection and respiratory pathogens were associated with elevations in cell-free DNA and a decrease in adenovirus burden. But what was really interesting to me in this study was that neither of these outcomes were actually associated with tacrolimus trough levels, which is what we're using now most often as a surrogate for ensuring someone has adequate immunosuppression on board. And so what I want to think about using cell-free DNA is how can we use it to inform how we taper immunosuppression post-transplant? And so this was a proof of concept study done in 21 kidney transplant recipients who had their mycophenolic acid dose reduced on the basis of their cell-free DNA. So those with negative cell-free DNA values had their mycophenolic acid dose reduced per nephrologist discretion, and those with elevated levels had their dose maintained. On average, they had a 50% dose reduction in the low risk cohort and no rejections or graft loss. While in the elevated risk cohort, there was one graft loss in this study. So again, this was a very small observational study that really showed proof of concept for how we could consider titrating immunosuppression incorporating cell-free DNA into this decision. And so, where I think these biomarkers have a lot of utility is when we combine them. And so, often we're presented with the situation where a patient presents with graft dysfunction. We may check an cell-free DNA level, which may be elevated, but this doesn't necessarily tell us if they're infected or having a rejection episode. And so, having a TTV viral load on hand could actually give us a better understanding of the patient's immune state and whether they're under or over immunosuppressed at that time. And finally, the last thing I want to talk about is how we titrate antiviral prophylaxis in this protocolized approach. And so, guidelines currently recommend considering two main factors, largely the CMV risk and the time post transplant, for determining how long we're going to utilize antiviral prophylaxis after transplant. However, we now have new tools, including CMV, cell-mediated immunity, that we can use to guide our antiviral prophylaxis duration after transplant. So this was a recent multi-center, single-arm prospective study done in kidney, liver, and heart transplant recipients. And in this study, they used quantiferin CMV cell-mediated assays to determine when antiviral prophylaxis was stopped. So those with a positive assay had their antiviral prophylaxis discontinued. If the CMV CMI assay was negative, they continued on 6 months of antiviral prophylaxis. And they had two main interesting findings in this study. Is one, the mean time of prophylaxis was around 90 days shorter in those who had a positive assay and were moderate risk for CMV compared to those who did not have a positive assay. The other thing I want to highlight is that in the high risk group, there was only one patient who had a quantiferin CMV immunoassay that was positive, showing that there's not a lot of utility for using this in the high risk population. But despite a shorter prophylaxis period, they actually found a significant reduction in CMV viremia in those who were CMV immunoassay positive, despite the shorter prophylaxis period. So overall, I think this really shows that we can make more informed decisions on who and when to stop our antiviral prophylaxis in that considers more than just time post-transplant. So altogether, I think there's several pros of transplant precision medicine and using it as an approach. One, it's really more of a proactive medication management approach that gives us an improved understanding of a patient's immunosuppressive burden, and really gives us more potential to individualize immunosuppressive and antiviral prophylaxis regimens. However, on the flip side, utilizing a transplant precision medicine approach makes things really hard to research because we may be doing something differently for every patient. It's also unknown at this time the impact that this may have on long-term outcomes or if there's any significant difference on drug toxicity. Furthermore, it does require ongoing evaluation and personalization for it to be effective, which translates into an increase in costs, in both cost and resources. And that concludes my presentation. Thanks all for joining today. I'll take questions at the end.
Yes, thank you very much, Krista. Wonderful talk. And as I say, keep your questions coming. We'll move on to our next presenter, and that is Sarah Cullivan. She is a pulmonologist in the National Pulmonary Hypertension Unit at the Mater Hospital in Dublin. And her talk is entitled The PH Power Play, Turning Data into Action.
So thank you so much for having me today. It's great to be here. So I'm going to talk about a little bit today about the evolution of risk assessment in pulmonary hypertension and how we practically use this in clinical practice to aid prognostication and guide treatment decisions. And then I'll move on in the second half of this presentation to talk about precision medicine and how it fits in. So any of you who work in the field of pulmonary hypertension will know that immense progress has taken place in recent years, but it's a relatively young subspecialty. The first clinical description of what was then known as primary pulmonary hypertension, or PPH, was published in 1951. And it wasn't until 1973 that we had our first World Symposium on Pulmonary Hypertension. And this was very much prompted by the epidemic of anoxygen-associated PAH. And at this meeting, they reinforce the importance of right heart catheterization to diagnose the condition. In the early 1990s, we got our first prognostic equation in pulmonary hypertension, which I'll come back to shortly. Our first FDA-approved therapy with epoprostenol. and our first cohesive clinical classification system, which we still use today. And more recently, we have had modifications in the hemodynamic definition of pulmonary hypertension, and we now use a threshold of a mean pulmonary artery pressure more than 20. And we've had refinements in risk stratification and an expansion of treatment options. And work has been ongoing in the background with precision medicine in the field. So as you know, to diagnose PH, we get a right heart cath, and once we confirm it, we then assign patients to a clinical group. And the focus of this talk will be Group 1 pulmonary arterial hypertension. And once patients are assigned to this group, we then do a risk assessment, and this helps aid prognostication and guide treatment decisions. So the when, where, and how of risk assessment. So typically we perform risk assessment at the time of diagnosis and then at regular structured intervals, usually 3 to 4 months. And we use multi-parametric risk assessment tools. And the reason we do this is we know clinical gestalt is not very good at estimating risk. It frequently underestimates the risk of disease progression. And there's no single variable that we can use to provide sufficient prognostic information. But irrespective of what tool you're using, you very much need to get patients into a low risk profile in order to improve their outcomes. So how do we do this? So I briefly alluded to our NIH equation, which was first published in 1991. And this used three hemodynamic variables at right heart catheterization to predict mortality in patients with PPH. So these were mean pulmonary artery pressure, mean right atrial pressure, and cardiac index. But as you all know, right heart catheterization is an invasive procedure, so it's not practical to use at every visit. And since then, we've seen the development of a number of different risk assessment tools, tables, and equations. And a lot of these have been derived from registries, such as the French PH registry, the Reveal registry, the Compara registries. And in 2015, we had the publication of the ESC ERS guidelines for the diagnosis and treatment of pulmonary hypertension. And within these, we got a really nice risk assessment table, which I'll come back to now shortly. But this really reinforced the importance of structured and regular risk assessment. Um, and really, the decision on what risk assessment tool or table to use in clinical practice is often guided by physician preference and even geographic location. For example, in our centre in Dublin in Europe, we typically use the ESC ERS risk assessment table, whereas I understand the Reveal equations are more popular in the US. So I'm going to talk about these two in a little bit more detail now, how we use them in current clinical practice to enhance prognostication and guide treatment decisions, and then I'll move on to talk about precision medicine. So the Reveal calculators, a lot of you are probably quite familiar with these. These were first published in 2010, and the example highlighted here is the Reveal 2.0 equation. And this uses modifiable variables such as BMP, walk distance, functional class, and unmodifiable variables such as your PAH subgroup or your age. And depending on the sum of the points, patients are stratified into low, intermediate, or high risk of 1 year mortality. And this equation uses both non-invasive and invasive parameters. So they've also developed the Reveal Light 2 equation, and this is quite practical to use on a day-to-day basis because it uses non-invasive and modifiable variables. And once again, you'll see patients are stratified into low, intermediate, and high risk. Looking then at the ESC ERS risk stratification table, which is what we use in our centre here in Dublin. This was first published in 2015 and it was further refined in the 22 guidelines. And while it was originally derived or created using expert consensus, it's since been validated to predict morbidity and mortality. It only uses modifiable variables, which can be both invasive and non-invasive, to divide patients into three strata. So this is low, intermediate, or high risk of mortality over the next year. But similar to the Reveal Light 2 equation, they also have a non-invasive method. So often at follow-up visits, we'd use this non-invasive 4-risk strata model, where we get functional class, walk distance, and BMP, and we divide patients into low, intermediate high, or high risk of mortality. And the reason that they further substratified the intermediate risk group is because we were noticing that between 60 to 70% of patients were falling into this group, but having very different treatment regimens and different outcomes. So this allows for a more nuanced approach. But irrespective of what risk assessment tool you're using, once again, the aim is to get patients into a low risk profile using your approved therapies. So, as you all know now, we have four general treatment pathways that we use: the well established nitric oxide, endothelin, and prostacyclin pathways, and more recently, the activin signaling pathway with sotatercept. And this flowchart is taken from the Seventh World Symposium on Pulmonary Hypertension last year in Barcelona. And you'll see they recommend performing risk assessment at the time of diagnosis, and that can help guide your treatment decisions. And it's really only relevant at that stage if your patient is or isn't high risk. If they're not high risk, you can go on and consider double combination therapy with your endothelin receptor antagonists and your phosphodiesterase type 5 inhibitors. But if they're high risk, you really should be considering parenteral prostacyclin. And then you see them again at the 3 or 4 month follow-up visit. And now using the non-invasive four-strata model, you can see it provides further recommendations to guide treatment decisions. So for example, if your patient is intermediate high risk, you might reconsider parenteral prostacyclin or adding an activin signaling inhibitor. So now you're all up to date with the evolution of risk assessment in the specialty, current trends in risk assessment, and how we use that then to guide prognostication and even treatment decisions. I'm going to move on and talk a little bit about precision medicine in the field. And I assume if you're attending this talk, you probably already know what this is. But just to provide a little bit of a background, so precision medicine is an integrative approach where we take all of that data we've already described as part of our risk assessment and we incorporate it with advanced panomics to allow for deep phenotyping. So these are things like genomics, transcriptomics, and proteomics. So as you can appreciate, you require a lot of data. So often you'll require the support of artificial intelligence or machine learning. And this way you can overcome some of the limitations of reductionism in our current practice, which may fail to consider individual patient differences. So this is a nice illustration just to give you an overview of how precision medicine might work in pulmonary hypertension. If you just focus on the first section here, you'll see patients are grouped by their endophenotype or gene-associated endotype, such as their BMPR2 status. But you could see if you then use your integrative omics and analyze this data, patients are segregated into new clusters. So despite having similar endophenotypes, these patients are biologically distinct and have different disease profiles. And this can then guide a precision approach to their care. And over the next few slides, I'm going to give you a very brief overview of some nice studies which provide an example of how precision medicine can enhance prognostication, guide treatment decisions, and even guide new drug development. So the first study I thought I'd talk a little bit about is a multicenter observational study that was published in 2017, which used proteomics to create a panel score using 9 circulating proteins. And these could be used to predict survival, and they're outlined there. The function of these proteins was quite relevant, for example, related to myocardial stress and inflammation. And the group were able to look at concentrations of these 9 proteins and create a score of 0 to 9. And this enhanced risk assessment independent of the established biomarker NT-proBNP and the reveal risk equations. So it's a really nice example of how precision medicine and proteomics can further enhance risk assessment. The second study I wanted to mention was the Stratosphere 1 study. Now, this hasn't been published yet, it's currently under review, but it was presented at ERS this year. So, in this study, this group designed a transcriptomic biomarker panel of the BMPR2 pathway in peripheral blood. And they wanted to use this to show engagement in clinical trials and to find a biomarker panel that would associate with clinical endpoints. So they developed this BMPR2 biomarker panel of 8 genes, which are highlighted there. And then using unsupervised machine learning, they clustered patients into 1 or 2 groups based on their biomarker panel level. And these were associated with long-term survival. And they also looked at this biomarker panel level in patients treated with sotatercept and showed significant changes. So, if we move on then to talk about precision medicine and its potential role in therapeutics and pulmonary hypertension, there's a lot of interest in the potential role of pharmacogenomics to help predict the clinical response to therapy. And just to give you some examples of studies that looked at this, there's a study by Benza and colleagues published in 2015, which looked at over 700 patients enrolled in the STRIDE trials, which were looking at the drug cetaxetine, which is an endothelin receptor antagonist that we no longer use. And they identified a gene variant that was associated with improvements in functional class and walk distance, potentially identifying a subgroup of responder patients. And then, on the other hand, more recently, we have a case report of a patient who was treated with sotatercept who had hereditary pulmonary arterial hypertension and a missense variant in GDF2, which encodes for BMP9, which, as we're starting to understand, is increasingly relevant to how sotatercept works. And in this patient, sotatercept was ineffective. So it just gives you a taster of how pharmacogenomics could help direct appropriate therapy, mitigate waste, and even avoid unwanted side effects, which will become increasingly relevant as more therapeutic options become available. And if we just stick with sotatercept for a moment, there's a really nice study published in the ERJ last year where Lawrence Saval and colleagues performed large-scale proteomics on patients enrolled in the PULSAR and STELLAR trials of looking at the drug sotatercept. And they provided really important insights into how this drug works. So not only did sotatercept mop up those activins and growth differentiating factors, but it also led to reductions in BMP9 and 10, which isn't something that we were particularly anticipating. And a lot of you might know that levels of BMP9 and 10 are implicated in hereditary hemorrhagic telangiectasia or HHT. And in patients treated with sotatercept, we see a lot of HHT-like side effects like epistaxis, bleeding, telangiectasia, and pericardial effusions. So this precision medicine study provided really important insights into a drug that we were already using and has helped shape future studies in the field and drug development. And to give you one such example, HS235 is a novel activin signaling inhibitor, which has been purposely engineered with high potency for those activins and those growth differentiating factors, but virtually no neutralization of BMP9 and 10. So you're trying to avoid mopping up your BMP9 and 10 to avoid those HHT-like side effects that we see with sotatercept. And this drug has demonstrated good efficacy in preclinical models, and they're currently recruiting for phase 1b clinical trials in humans. So I hope I provided a very brief overview of some of the clear opportunities that are provided by precision medicine with potentials for improving prognostication, guiding treatment decisions, and even guiding new drug developments. But there's clear barriers to its practical implementation in clinical practice. And this would be the obvious things like cost, ensuring equitable access, training for healthcare professionals, health literacy and informed consent for patients. This data is often quite sensitive, and ethical implications, including data privacy and regulation. So, to summarize, the preceding decades have witnessed some really impressive advances in the fields of pulmonary hypertension, and there's been important refinements in risk assessment and the expansion of treatment options. And I think from our perspective, it's very clear that precision medicine has a role in the future of the field, but we'll need to carefully consider the benefits and the barriers of this prior to its implementation in clinical practice. And once again, I'm happy to take any questions, but we'll take them at the end.
Thank you very much, Sarah. That was fantastic, very interesting talk. Hopefully, you get lots of nice questions for it. Moving on now to our last presenter for the evening. This is Ian Hollis. He's the Associate Professor at the Department of Pharmacotherapy and Experimental Therapeutics at the University of North Carolina in Chapel Hill. And he's going to talk to us about making it personal, rethinking anticoagulation in the era of HeartMate 3.
All right, thank you for that introduction. I will go ahead and jump in. I'm here at UNC in Chapel Hill, North Carolina, and I've been taking care of LVAD patients for about 18 years or so now. So I'm going to talk to you about how we might be able to customize their therapies moving forward. And so I'm actually going to start with a patient case and an audience response question. And so we have a patient, a 65-year-old woman. You can see her past medical history here. She presents to an outside hospital with an ST elevation MI and new acute heart failure. And she has two drug-eluting stents placed, one in the proximal LED and the other in her RCA. After about a week of management at the outside facility, they put in an Impella and send her to your facility. After a few days of evaluation, you decide she's a good HeartMate 3 candidate. The surgery goes well. The patient's recovering in the cardiac surgery ICU. She's stabilized, ready to take oral meds and make progress. So I've got a few current, sort of pertinent medications and some laboratory values as well for you to consider. And so I'll let you take a look at those briefly. And so I have a question, and we're going to don't put anything in the chat because I have some audience response software. The question is, in addition to the heparin that she's already on, what do you think the next step is for this patient with a fresh LVAD and two fresh drug-eluting stents? You can see, unlike your options in school where you were limited to four, I'm going to give you up to six things that you can choose from. And I actually have a poll everywhere. And so if you would like, go ahead and scan the barcode, and you'll be able to get your answer options up. And then go ahead and choose. And you can see it's all the answers I just showed you. We have triple therapy. We have aspirin and warfarin. We have clopidogrel and warfarin. Um, Other options as well. So go ahead and log in, start putting your answers in. And I'm curious to see what people think. You also have Pixaban options. So everything is on the table. I'll wait until I get a certain amount of responses before I move on. All right, they're starting to come in here. I will admit I'm curious to see what people choose because I think there may be some differences of opinion. All right. Well, we'll go ahead and show what people have chosen. Wow, we have an interesting spread. So we have a little bit of triple therapy, a little bit of aspirin and warfarin, some Plavix and warfarin, and some warfarin alone. This is actually more spread out than I ever thought it would be. So this is great. We're going to come back to this. Let me clear the responses. And we're going to come back to this in the future. And so let's jump in. And so what would the standard of care be without a VAD, right? So let's go to the ACS guidelines. Of course, dual antiplatelet therapy would be standard of care. Drugs of choice are prasugrel or ticagrelor. However, if patients either have a contraindication or the inability to access one of those medications, of course, clopidogrel is reasonable. Now, pertinent to our case is the fact the patient also needs oral anticoagulation. And so the guidelines specify a 1 to 4 week period of triple therapy, preferably with clopidogrel, along with the oral anticoagulant to kind of bridge the stents with the bleeding risk. And so, what do the ISHLT guidelines tell us? Well, you'll find that many of the statements here are fairly general and not helpful for customizing our decisions at the individual patient level. So you can see anticoag and antiplatelet therapy according to your predefined institutional goals, which isn't going to be super helpful in our case. Now, the aspirin recommendation is pre-ARIES, and so you can see they're recommending aspirin with a now infamous class 1 level of evidence C recommendation that has been debunked, and I'll touch on that in a second. And then what about antiplatelet therapy beyond aspirin? Well, we don't have a lot of information on that. The guidelines are not particularly helpful on that as well. So I did what any white-collar professional would do in the year 2025, and I asked ChatGPT what it thought. And so here's what it came up with. It says there's no trials or guidelines that specifically tell you what to do in a HeartMate 3 LVAD with a recent drug-eluting stent. The safety of triple therapy data on that is extremely limited. ARIES shows that skipping aspirin in the broader population may be reasonable, but what about a recent drug-eluting stent? It points out that DOACs remain investigational, and if you did do dual antiplatelet therapy, how long to do it is also unclear. So ChatGPT didn't necessarily give me any answers, but it did do a very nice job of summarizing all the questions. And so with that, I'll move forward. Let's talk about the impact of these devices on platelet function. And so all of us have von Willebrand factor, and the high molecular weight von Willebrand factor is the one that's most responsible for platelet cross-linkage. And so I have a graphic of the conformational structure of that high molecular weight von Willebrand factor in the lower left. And so you can see specifically there are certain subdomains that are responsible for binding to glycoproteins and to collagen, and this is where the impact on platelets takes place. Of course, in patients with a continuous flow LVAD, many of you are probably aware that the circulatory shear stress leads to cleavage of these monomers by atom TS13 in that A2 domain. And so when you look at gel electrophoresis, what you see is that patients with an LVAD are missing many of those high molecular weight multimers, or at least don't have as many of them. And then that's redistributed to the low and intermediate ones that are not as good at cross-linking platelets. And so there's evidence that indicates that many patients have platelet aggregation dysfunction shortly after putting a VAD in place. And so I think everyone's familiar with ARES, which showed in a broader HeartMate-3 population that aspirin is not beneficial and creates a lot more bleeding. Recently, there was a sub-study of the patients in ARES who had specific indications for antiplatelet therapy, basically prior atherosclerotic disease. And so that was 41% of the overall population. And if you look in the upper right of this graphic, the overall results when compared by vascular disease versus not are not statistically different. So there's no interaction p-value significance there. Now, what's interesting is if you look at the raw rates of the primary outcome, which was freedom from hemocompatibility-related adverse events, it's actually much lower in the patients who got aspirin relative to placebo in the prior ASCVD group. And so let's look at why that may be. Well, I think what most people are interested in adding aspirin in a patient with a history of vascular disease is preventing thrombotic events. But what this sub-study shows us is that, if anything, it may actually be better not to use aspirin for the prevention of thrombotic events. Granted, there's no statistically significant interaction, but when you look at these point estimates, they're all kind of leaning in favor of placebo, although these are very low numbers. But we can at least say that adding aspirin is not helpful in preventing vascular events in patients with a HeartMate-3. What is, I think, very interesting is when you look at the rates of bleeding split by the patients with prior atherosclerotic disease or not. And so you can see in the panel on the left, which is panel A, these are the patients with a quote unquote indication for aspirin. And their freedom from bleeding is actually worse than the patients who would not have had an indication for aspirin. So paradoxically, the patients who have an indication for aspirin actually do worse when you add it to aspirin in the setting of an LVAD or a HeartMate-3 LVAD. And this is a quote directly from the study that says not only does it not appear to be beneficial, but that vascular disease may actually identify patients who would be worse off with aspirin. And so with that, I want to pivot to some risk stratification, which I know has been the theme of the presentation so far today. One of the first and most well-known was a Utah bleeding risk score. Now, this was single-center data, and it was about a 15-year period, but these are legacy devices. So this is the HeartMate-2 or the HVAD. But what they were able to do is a multivariate analysis to identify specific patient factors that are predictive of GI bleed. And what they did is they assigned points, and you can see some of these things are weighted more heavily than others, almost like a CHADS VAS score in patients with AFib. And then they categorize patients as low, intermediate, or high risk. And so if you think about our patient from the case, she would meet the criteria of greater than 54, a history of CAD, and poorly controlled glucose at baseline. And so when they split the patients into these three tertiles, you can see there is a significant difference in the likelihood of a GI bleed downstream. And so the patients who are intermediate and high risk had a very high risk of GI bleed in the subsequent period. And so again, taking a quote, well, I'm sorry, let me come back to that and let me go to another model. A more contemporary model is the Michigan bleeding risk model. So the difference here is this is the HeartMate-3, all right, so our more contemporary device. And they use 6,500 patients across multiple centers because they pulled this data from Intermax. They had a 12-month follow-up, and their interest was in time to first GI bleed, and that was regressed against things that are known to cause GI bleed to sort of control for those. And what they arrived at was table 3 on the right. So you can see they have a lot of factors that go into this equation. The ones that, again, go back to our patient, advancing age is a risk factor, female sex. Our patient has an impella, so it's reasonable to think she's New York Heart Association class 4. There's an incremental increase in bleeding as your BUN goes up, and hers was 38, and her A1C at entry was greater than 7. And so this Michigan bleeding risk model also, they went ahead and stratified the patients into 3 tertiles. And so you can see the downward slope is not as great. So that means there isn't as much bleeding with a HeartMate 3, but the trends are the same. And so patients who are intermediate or high risk of bleed are at much greater risk of a subsequent GI bleed. Now, interestingly, the authors went ahead and created a risk stratification calculator. This is available for free online. I've included the link in the bottom right if you're curious. And so you can take your patient and their patient-specific characteristics and plug it into the calculator and get an estimated risk of GI bleed in the downstream period. And so plugging in our own patient's factors, we can see that at 6 months, our patient has a 20% risk of GI bleed, driven heavily by age and the vascular disease that she already has, as well as the uncontrolled glucose. So our patient, it would be potentially concerning if we were going to stack on a lot of antithrombotic therapies. And again, from this trial, one of the quotes, patients at medium or high risk might actually be candidates for reduction in antithrombotic therapies. And so that's something we have to take into account in caring for our patient. So I'm going to go back to the case, okay, and I'm going to let you look at this again and just refresh. There's our patient with all her risk factors. She's got a 20% risk of GI bleed according to the Michigan risk score. And you can see some of her information there. And I'm going to pop this back up in a second. I want to let you consider your options. And I'm going to bring the poll everywhere back up. And I'm going to let people vote again. And I want to see if there's been any changes in how people feel. We'll go ahead and jump ahead and see what people decided. Okay, well, it looks like I've at least scared people away from triple therapy. Um, we actually have probably more Plavix and warfarin, and I think we've added a little bit of just warfarin. So it's interesting. We definitely had a change in our distribution. So let me tell you what I think, and these are just opinions. Okay, this is based on my estimation of the evidence. I think a single antiplatelet agent with warfarin would be reasonable. I noticed there was a lot of clopidogrel in the selections from the crowd. I actually think that's very supportable because the data we have from general cardiovascular medicine is increasingly showing that clopidogrel has a better balance of bleeding and thrombotic events. So I think you can make that case for sure. My opinion, anything that we do should be for no longer than 30 days. And so I think if you can get away with single antiplatelet therapy, knowing that the patient has platelet dysfunction at baseline, along with your anticoagulant, I would try to do that for 30 days and then get out and drop back to single agent warfarin. And let me make a point. I would only include the antiplatelet therapy because of the RCA stents. I think if the patient only had left-sided stents, you could make an argument that they're not that clinically significant once you place the VAD in, and that the risk of antiplatelet therapy may not be worth it. So I probably would have done warfarin monotherapy if the patient only had left-sided stents. And so with that, I want to pivot to a different case. This will be our second and concluding case. So now we have a slightly older patient, 77-year-old man. He had a HeartMate 3 put in roughly a week ago. You can see his past medical history, most notably a history of PE a long time ago, treated with warfarin that resulted in a GI bleed. So you can see some of his labs as well. He's been on heparin since the R. He's not had any problems. He's ready to take meds by mouth, and the discussion ensues on rounds. How are we going to manage this patient? And so these are going to be your options. And so you can see I'm making this highly customizable. I'm letting you basically do anything you can imagine. We've got aspirin and warfarin, warfarin with several different INR goals, or apixaban if you're interested in that as well. And so I've got another audience response. I want people to go ahead and vote. And I want to see what people think about this 77-year-old patient, remote PE treated with warfarin that resulted in a GI bleed, a little bit of mild CKD. What do we think we're going to do for this patient? You got either a apixaban dose, several warfarin INR goals, or standard dual therapy. I'll give people a few seconds to vote. All right, so the votes are coming in. Let's see. Well, we got a lot of standard INR goal, a little bit of lower goal, a little bit of apixaban. Very interesting. Okay, this is perfect. Let me clear the responses and we'll keep moving. So I think many of you are probably familiar with the Magentum-1 study. This was published shortly after the original Momentum proof of concept trial. And they took 15 very carefully, arguably cherry-picked patients at two large volume VAD centers. After a 6-week period of quote unquote normal antithrombotic therapy, they were de-escalated to an INR of 1.5 to 1.9. Over the subsequent 12 months, the only hemocompatibility related adverse event was one patient with GI bleed. Now, it's important to note in the lower left, they strictly eliminated any patient with a history of thromboembolic events or high risk for thromboembolic events. So this was a very clean, highly cherry-picked population. If you look on the right, the time in therapeutic range was 75%, which does not really represent reality in VAD land where it's normally around 50%. So does this apply to our patient? Probably not perfectly. Our patient's got a history of VTEs, so they wouldn't have been included in this trial. So more recently, we had an interesting study from the University of Kentucky where they talked about their change in INR goal to a target of 1.8 to 2.2. So they made this change in 2019, and then they went back and looked at how it went. Some of the patients had that INR goal from the time of VAD. Others already had their VAD and had to be adjusted after the fact. And they looked at 6 and 12-month hemocompatibility related adverse events. So does this represent our patient? Well, these patients were a lot younger. Um, they did have a history of thrombosis, remote history of bleeding. A lot of these patients were also on aspirin because this is pre-Aries, so that's worth noting as well. How did it turn out? Well, as you can imagine, when you have an INR goal of 0.4, your time in therapeutic range is going to be predictably bad. But the important thing is overall thrombotic events were very low, only one across 26 patients in this trial. And the bleeding events were not significantly worse or anything to be concerned about. So this, to me, presents this as a very reasonable option for select patients. What about apixaban? Well, I have a summary of the 3 major apixaban trials. Many of you are probably familiar with these, starting with .HM3. This is the 6-month analysis of DOAC-LVAD, and then, of course, apixaban. Key things to think about here, all 3 of these studies, the patients had a period of warfarin before they were transitioned to apixaban, so that quote-unquote high-risk period after VAD was not included. Many of these patients were also on aspirin, but the important thing you'll see in the apixaban patients, nobody had any thromboembolic events while on apixaban, and so that's arguably the most important endpoint. Focusing in on apixaban and the types of patients that were enrolled, again, these patients weren't as old as our patient, predominantly white males. This was done in Europe and Australia. Not many destination therapy. Clearly, our 77-year-old patient would be destination therapy, so it's not a perfect fit. But what we can see is that in these types of patients, that apixaban matches warfarin and does not lead to any increased thrombotic events. So I want to bring this patient case back up, having shown you all that, and see if anybody has any different opinions. And so again, here's our choices: aspirin and warfarin, warfarin with the different INR goals, the 2 different apixabans. I'm going to pop the poll everywhere back up. Actually, let me clear the responses so we can start over. All right. Give people a second to vote without seeing what other people say, which I know can be biasing. All right. Let's see what we got. So we still have some 2 to 3 folks, a little 1.8 to 2.2. And actually, a lot of the apixaban 5 folks have moved over to 2.5. So maybe I swayed some opinions there. So let me give you my thoughts. Again, these are opinions. Okay, so open to debate. I think 2.5 BID of apixaban is potentially reasonable. Now, none of the studies I showed you used apixaban immediately after LVAD, but there is a separate study that I didn't have time to share that looked at 30 patients, 30 adult patients who got apixaban directly after their VAD, and they had no thrombotic events either. So I think it's probably reasonable to at least try apixaban early after VAD. And this is a good opportunity for the lower dose in a patient who might be slightly higher risk of bleed. I also think the lower warfarin INR goal, you'll notice I've cheated a bit and made it 1.8 to 2.3 to make it a little more reasonable for us to be able to actually hit that goal. But the important point here is in neither case are we using any aspirin. And so I hope moving forward that even if we start using apixaban, we don't bring back the aspirin. When you look at the apixaban trials, the majority of the bleeding events that do occur are in the patients who were also given aspirin, which tracks with everything we already know about aspirin in cardiovascular medicine. So these would be my choices that I think are reasonable. And with that, I'll wrap up. So we've got new evidence about aspirin, apixaban, and adjustable INR goals. This allows us to customize to the specific patient in ways that may be evidence-based or reasonable. Use the patient-specific characteristics and use some of these prediction models. I mentioned the Michigan bleed risk scores available online. And so I recommend trying that out on your patients and seeing what you think. And I want to make one more statement that might seem like an oxymoron, but standardize the customization, meaning if you are going to treat specific patients in certain ways, try to get team agreement to treat all of your patients in that way so that then you can aggregate your data and report it and we can all learn from it. So with that, I will stop and we'll have time for questions.
Yes, thank you. Thank you very much. Lovely, interesting talk there. We just got a couple of minutes left here to go through some of your questions. If we don't get a chance to get to your question, please submit them via the ISHLT Connect or on the ISHLT YouTube channel, and I'm sure the presenters will be fit to get back to you. If I kick things off, first of all, just one little short question from me to Krista about TTV. I actually come from the study was run in Hanover, and we're still waiting for the final results. Do you have any experience with it in terms of the lag time? There's some kidney data that it takes about 3 to 4 months from changing your drugs to seeing an effect on your levels. Do you think that will have an impact on how useful it will be in terms of a monitoring tool?
Yeah, that's a really good point. I've definitely seen in the literature some lag time reported. So I don't think it's something you can really use as quickly as like cell-free DNA when something's going on. So I almost envision it being used like, okay, we get like their baseline at whatever, 3 months post-transplant when we know it's gonna peak. And then you're just kind of like I'm avoiding saying protocol, but you're standardly getting it at certain times post-transplant so that you have it there and correlating it with adjustments in immunosuppression. But that is a good point. You can't, you're not going to get as quick results. But to that point as well, in that trial that you guys did, you were still titrating the immunosuppression using that, and there was no difference in acute rejection in those preliminary results. So I think it is possible to still titrate immunosuppression on it.
I think
But just not
I
as
think
quickly.
our
Yeah.
experience. I think our experience of it, it might be better to think about it in terms of an HbA1c, in terms of what's going on in
Mhm.
the background. If you're that sort of
Yeah.
psychic with it, that would be fine. Okay, I'll check. Amanda, have you any questions?
Yeah, I was going to ask, Ian, do you routinely do DOACs for your HeartMate 3s now, or there a selection of patients that you don't do DOACs for?
Yeah, it's a good question. We have actually built out an early protocol for identifying patients that we are going to try DOACs in. And I'm not going to itemize all the different criteria, but I think our team agreed we didn't want to do that early post-VAD period because those major studies, I say major, they were 30, 40 patients each, but those studies didn't include the immediate post-VAD apixaban. So we're waiting and converting patients after the fact. Um, we kind of created a list of patients we thought we were good and less good candidates. And we have a periodic team meeting where the coordinators or other folks can bring individual patients to the meeting for potential conversion. And then we talk about them as a multidisciplinary team. And I think that's nice because then the pharmacists and the coordinators and the different physicians have a chance to kind of weigh in on whether they think that's a good patient to convert.
Thanks, Ian. So really a personalized approach. And I did have a last question for Sarah, but it seems like we're out of time. So we'll have to continue the conversation on Connect or on YouTube. Thank you everyone for their time. Thank you for the speakers.
Yeah, for me too. Thank you.